number system in acute stroke patients. My name is Arndt Dörfler. I'm an interventional neuroradiologist at the University of Erlangen in Germany. Here are my speaker disclosures. And I think many of you are familiar already with the penumbra system, a mechanical device designed to reduce clot burden in acute stroke. And there are multiple options for thrombus aspiration, and selection of the aspiration platform is mainly determined by the target vessel diameter and the ADR architecture. The system components are basically consistent of a red perfusion catheter for navigation and aspiration, and the so-called separator, also enabling the continuous aspiration. And at the time of the study, there have been 3 sizes available as shown on the slide. In the meanwhile, you've heard it already yesterday, there's a larger perfusion catheter available, an 054 size, and of course you need an aspiration system and the tubing. And the penumbra pivotal trial results have been published last year in Stroke, including 125 patients, resulting in a high recanalization rate of more than 80%. Now I would like to present the post-market experience of the penumbra system. It's a retrospective multi-center case review, 157 patients at 7 international centers, and assessed according safety and efficacy of the penumbra system. So accordingly, primary endpoints have been revascularization of the primary occlusion site, procedural serious adverse events, and secondary also an analysis of outcome according to the modified ranking scale at 90 days, incidence of symptomatic hemorrhage intracranially, and all-cause mortality. And here you see the baseline characteristics of this post-marketing study. The majority of patients had an MCA occlusion. And here for comparison, the characteristics of the pivotal trial. And you see that mainly severe strokes have been treated with an NIH score of 16 and 17.6 respectively. Time to revascularization has been for the post-study 4.5 hours from symptom onset to arterial puncture, and the mean time required for revascularization had been 41 minutes for the post-study. And here you see some illustrative cases. This was a young man presenting with an acute vessel thrombosis, already visible on the CT scan. We do CT imaging during the first 4.5 hours in our patients. These patients are prone to intravenous thrombolysis. And this was clearly visible on the CT angiography, and the lower line shows the complete recanalization after the use of the penumbra system, also resulting in a good functional outcome. And the second case here, as an illustrative case, was a 73-year-old man with a complete MCA occlusion. You see also the perfusion deficit in the perfusion CT. We use perfusion information in all of our stroke patients, either by CT or MRI, depending on the time window. You see here the complete MCA occlusion with a bad collateral flow or absent collateralization, and the subsequent recanalization with the use of the penumbra system, and also a quite good outcome with only a small infarction restricted to the basic ganglia. This is another case. Nearly no diffusion disturbances on the diffusion weight scan, a clear perfusion deficit, whole MCA territory. We had an ICA occlusion in MR angiography, and also an MCA occlusion. And this is the slide showing excess after carotid artery stenting, and then the recanalization with the penumbra system. First of the internal carotid artery, and then subsequently of the middle cerebral artery, as shown here. So what about the recanalization rate? It was TIMI2 and TIMI3 altogether resulted in a recanalization rate of 87% compared to 82% of the pivotal trial. And what about intracranial hemorrhage? We had the symptomatic intracranial hemorrhage in 4% of the patients. We had, of course, a higher hemorrhage rate, but the majority has been asymptomatic in these patients. And what about procedural serious adverse events? There have been a total 9 in this series. Only 2 had been device related. And about device reliability, we had 2 catheter fractures and 1 separated tip detachment. You've heard already such a case in the yesterday presentations. And importantly, none of these resulted in patient injury. Importantly, the outcome, as measured according to the modified ranking scale at 90 days, we had 41% good outcome of a modified ranking scale of 2 or less after 90 days. We had 20% all-cause mortality. And this is in comparison with the pivotal trial. Again, high recanalization rate, procedural SAS 5.7%, symptomatic intracranial hemorrhage 6.4%, 20% mortality, considering that we treated severe stroke patients, and a 90-day modified ranking scale of 2 or less in 41% of the patients. And how did recanalization affect the outcome? This is clearly shown here that the patients with a recanalized vessel had significantly higher good outcome, as you can see here in 45 of the patients with a good outcome according to the modified ranking scale. So we can clearly conclude that the penumbra system is effective and sufficiently safe, and that successful revascularization by the penumbra system contributes significantly